Head of Pharmacy Practice, Sri Ramakrishna Institute of Paramedical Science, Coimbatore. Dr. Sriram is appointed to serve as Secretary of the Bioethics Unit of International Network of UNESCO Chair in Bioethics. He has delivered various lectures on clinical research, pharmaceutical care, medication errors, adverse drug reactions, etc. at various national and international conferences. So, I request you to please start the session.
Thank you. Thank you very much for the nice introduction. Be a part of this, right? I'm thankful to this Chaho and the other organizations, including the IPA and the Hiranandani Hospital and the other organizations who are involved in this. So at the outset, I'd like to start with the definition. Let me go for the next slide. What is the medication error? Everybody has to understand that what is medication error. So everyone knows that it is a preventable event. According to NCC-MERP guideline, that is National Coordinating Council for Medication Error Reporting and Prevention, right? It is a preventable event. So this is very important that 100% these medication errors are preventable when compared to other like adverse drug reactions, which are sometimes not preventable, whereas these medication errors are 100% preventable, right? Next slide, please. So according to this, Lucien Leap, he's a professor and he is a person who is also called as father of patient safety, right? Lucien Leap, he is from the Harvard Medical School. He is the one who said that no one makes an error on purpose. He also emphasized that the errors are not because of the people, it is because of the system. The system error is more involved than because of the people. Next, please. So no one admits their error, isn't it? Whatever errors committed, it is very difficult for them to admit themselves. So next please. So in official book that is by the Institute of Medicine, now it is called as National Academy of Medicine. In that, it is very well reported that there are two reports very significantly reported, that is methotrexate when it is given instead of weekly dose, if it is given daily dose, and the patient died. And similarly, the units insulin, instead of 20 units, the 20U is mistakenly taken as 200 and it is given and the patient died. Next, please. So medication errors are not only here in India, in developed countries where we say the healthcare team are well developed and well organized. So there also you could see medication errors making headlines. Next slide. So medication errors are not only here throughout the world, the medication errors are numbering more in the healthcare system. Next slide, please. So here I've given statistics where the FDA has reported that around 1 lakh reports annually are reported in case of medication errors, and 10% of the hospital patients are affected with medication errors. And it is said that more than around 48 to 53% of the medication errors are because of IV medication errors, where the nurses are more involved in giving the medication. That is where the more errors are being found. And 1 in 5 Americans experience this medication error, and 7 million US patients yearly experience these medication errors. And it is said that the drugs which are used for the nervous system, respiratory system, anticoagulants, and antibiotics are the most frequent category of drugs which are involved in medication errors. So as we all know, these medication errors, according to NCC-MERP guideline, it is divided into, or it is categorized into 9 different categories, starting from A to I, and the severity of the error increases from A to I. So we know that category A is no error, then error with no harm, error, harm, and error which leads to death. Next slide, please. So the major causes of medication error, who are the people who are involved in this medication errors? Mainly there are 3 healthcare professionals, that is the prescribers, the pharmacists, and nurses are the people who are involved in this, who can take a lot of steps to reduce this medication errors. If you see the prescription errors, it is said that the drug-drug interactions, that is the combination of the drugs in the prescription leading to drug interactions, are the major reason for medication error. And in case of pharmacists, the wrong medication which are dispensed, they are the one which leads to medication error. And in case of nursing errors, more of wrong rate and wrong time of administration. So here there is a model called a Swiss cheese model, which is developed by James Reason. So here the medication system, what are the defensive layers in the medication system and what are the potential medication system errors which can occur? For example, from prescription, then the transcription, interpretation of the prescription, then entering the order, then selection of the drug, labeling, checking the prescriptions, dispensing the prescription, and again till they reach the patient. There are a lot of areas, defensive layers where the medication system can be monitored properly. Here's few examples are given here, prescribing errors. For example, if a patient who are receiving the selective beta blocker atenolol and if they are prescribed with the another beta 2 agonist without taking the drug history, then it becomes harmful for the patient. And similarly, thiazide diuretics, if a patient on digoxin therapy, you know that digoxin therapy already the potassium levels have come down, and thiazide diuretics also causes the decrease in potassium level. So prescribing the aspirin to ulcer patient. These are a few examples which we know where the prescriptions, if without taking the adequate drug history from the patient, if the prescriptions medication errors. Here are a few prescribing errors, the name confusions with Lasix and Laxil, the Colex Dupholac. Recently, I've come across one is Longifen, which is Buclazin, and Logifen, that is Luliconazole, which is prescribed. There are a lot of areas where this confusion comes while prescribing, because whenever the senior doctors are there in the rounds and they say about a particular drug to be added in the prescription, the junior doctors, they write the drug. And one such thing which is recently I've come across is Epitra, that is levetiracetam, and Epitra is there, that is epirubicin. So when the doctor is asked for this levetiracetam, that is Epitra, which is the trade name, whereas it is written as Epitra, and this epirubicin is given. Similarly, Stalix is sitagliptin and Thalix is thalidomide, which is entirely different. So drug name confusions are there. Similarly, inappropriate use of decimals, that this basic things, which, for example, whenever with 0.4 milligram, you should not write as 0.4, it should be 0.4. Similarly, digoxin 2 milligram, writing 2 milligram is not 2.4. That colchicine again, after the point, there should not be any zero. Similarly, writing the name of the drug, and for example, here it is given Indrol, this is propranolol, that is Indrol 40. If it is written along with Indrol, the last letter, it looks like as if it is 140 milligram. Next slide, please. Next slide, please. Similarly, use of abbreviations, like short abbreviations when it is used. For example, I'm taking one example, that is DC for discharge as well as for discontinuation of the drug. The dispensing errors are up to 24%. According to literature, there are up to 24% of the dispensing errors are there, especially the wrong product, wrong strength, wrong dose, and wrong drug, and sound alike and look alike drugs. Here are a few examples. Next slide, please. Here are a few examples I've given here. Next slide, please. See, a 5-year-old boy who fell down was taken to the previous slide, please. Previous slide, please. Previous slide. Previous slide. Yeah. A 5-year-old boy who fell. Next slide. Next slide. Next slide, please. A 5-year-old boy who fell down was brought to the. I think slides are getting changed faster. Next, before this. Yes. So a boy was brought to the hospital. He was prescribed with Soronac, which is serratiopeptidase and diclofenac sodium, but while dispensing, the drug given was Serinase, and when he was taken to the taken home, and when he was taking the drug, abnormal movements of right upper limb was observed because of haloperidol. The Serinac and Serinase, right? The sound alike drug. That's a problem in this. Next. Next slide, please. So lookalike drugs, I've taken few examples here. These are atropine, pyramine, paracetamol. The photographs are taken here. You can see the all lookalike drugs. I've got 3-4 examples like this: Fluorouracil and multivitamin. Next. Carbamazepine and amantadine. The package looks same. Next. Yeah, nitroglycerin, 25 milligram and 50 milligram injection. They all look alike. Next, 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 please. Yeah, a few of the ophthalmic preparations, this heparin and heparin lock solution look alike. Next, please. Lisinopril and enalapril, topramycin and naloxone. See, few examples are taken with photographs just to make you understand lookalike drugs. Next. Yeah, this is a very important slide that there are common risk factors for this medication errors. What are the common risk factors? For example, the different route of administration, the confusion when the nurses are asked to give this drug, particular drug to the patient when it is written by the doctors in the prescription, the confusion comes whether it should be given IM or IV. Right? Similarly, the preparation of the drug, how to dilute the drug, which is the diluent to be used, how to dilute, what are the strength, the calculation, incorrect calculations. Then infusion rate, how much to be given for the patient. So all these are these risk factors which are involved, which can lead to this medication errors. Next slide, please. So I'll give you a few examples. Yes, next slide, please. So here are the list of drugs, which are all of us know according to ISMP guideline. It is the high alert medications. Acronym given is YEP-PINCH. So most of the times, these high alert medications are the one which has to be given, administered when two nurses are there, and the high risk medication should be administered with two nurses, and the document the same in the documenter. So these are the drugs which are more involved in this medication errors. Whenever these drugs are used, we have to be very careful. Next. So follow the 5 rights of medication administration, especially for the nurses, whether they are administering to the right patient, right drug, right dose, right route of administration, and right time. So whenever the administration errors, how to avoid these administration errors? Always, most of the time, the administration errors are because of duplication. The same drug is administered again, or the delay in administration of the doses, or the previous day's night dose was not administered, and again, the therapy becomes ineffective. Next slide, please. So there are some aseptic techniques which are violated, and that may be some of the reasons why these medication errors can happen. Say, for example, they don't remove the air bubbles, or gloves are not worn, not disinfected properly, etc. Next. So here are a few administration errors to how to avoid it. See, if the patient identity is not properly seen, then it can lead to medication errors. The storage of preparations, lookalike preparations side by side in the drug trolley, that also can lead to medication errors. Right, interruption during their work because of the external noise and poor lighting, and the calculations required is not being done properly. Next slide. I've given one example. I've taken one example which is there available in the literatures. It is, for example, a doctor, a pediatrician has ordered for 140 milligram of calcium chloride for the baby, 8 months old baby, without knowing that it contains, for example, this 1 ml contains 100 milligram. Instead of that, the nurse thought it was 10 milligram in 1 ml, and instead of 1.4 ml, she had administered 14 ml, and the baby died. Next slide, please. So these are the few examples which are there in the literatures. I'm taking from the official literatures where it is available. So here again, the calcium channel blocker was crushed and given. It should not be crushed and given, as it is extended release tablet. It is crushed and given, and the patient, the heart rate has reduced a lot. Next slide, please. Similarly, nitroglycerin tablet, which is a control release tablet, is 2.6 milligram tablet, which is given by the nasogastric feeding tube by crushing it, and it lead to the side effects or the adverse effects. Next slide, please. So here again, the wrong time the medication is given. An antiarrhythmic drug, dofetilide, is twice daily. It is given, that is 6 a.m. and 6 p.m. But what happened was the next day morning, 6 a.m., the operation was set for the patient, and the nurse in duty thought, okay, before the operation, instead of skipping the dose, she can give it 2 hours before, and she gave it by 4 a.m. in the morning. And it has become dose because night, without knowing the previous night, the dose was given only by 10 p.m. Right? She has given in the morning 4 a.m. and only 6 hours gap was there instead of 12 hours. Next slide, please. So here are some rate of infusions which should be displayed, especially in the nursing stations or the nursing near to the uh, drug chart. Say, for example, the calcium gluconate not exceeding 200 milligrams per minute, vancomycin, the maximum rate is 10 milligram per minute. So each and every healthcare professional, especially the nurses who are doing this infusion, who are incorporating the infusions into the patient's body, they should know the rate of infusion. Otherwise, the adverse effects of because of these medication errors can happen. Next slide, please. So here are a few examples which I have given. That is, for example, furosemide, not more than 4 milligram per minute. Otherwise, it will cause ototoxicity. Similarly, vancomycin, not more than 10 milligram per minute, can cause red man syndrome. Like this. Few examples are given. Next slide, please. So again, few examples of IV incompatibilities that it is all well documented. Evidence are there in the literatures. These two combinations should not be given in the same Y site. Furosemide, ondansetron. Few more examples are there. I think you can go on with the slides. Levofloxacin and piperacillin tazobactam. Again, microprecipitation occurs when it is taken together in the IV Y site. Next. Again, calcium gluconate injection with ceftriaxone injection. Again, a lot of documented evidence is there that it can cause turbidity if it is given in the same IV line. Again, ceftriaxone and clindamycin, again, the chemical decomposition of the drug happens because when it is given inside, we don't know what is happening inside the body. So it is all there. The documented evidence are there. So that training should be given for the nurses in these areas, especially the IV incompatibility area. Next, please. So here, this particular administration errors, I've given few examples here. For example, amoxicillin clavulanate potassium. The actual procedure to be done is reconstituted with 20 ml of water for injection and used immediately and given by slow IV injection over a period of 3 to 4 minutes. This is what the literature claimed by the manufacturers. But actual how it is done is it is reconstituted with 5 ml sterile water for injection and it is administered in just 10 seconds. Next slide, please. So I'm just, because of time, I'm taking only one example. I'm leaving these slides also with the organizers. So here again, the oronidazole administration as IV infusion in 10 minutes, actually it should be infused over 15 to 30 minutes according to the label plan. Next slide, please. So how to minimize these medication errors? So here are a few things which we can minimize the medication errors. For example, whatever the patient information, the entire patient and drug information has to be collected properly, whether the patient has got any allergy or the drug information, that is what type of drugs are being taken and already being taken, the drug chart reconciliation has to be done properly, and miscommunication regarding the illegibility because of the illegibility of the drug order or the prescription, look-alike, sound-alike drug, the storage problem, then delivery device problem. Next slide, please. So environmental factors, that is noisy environment in a very populated patient hospital, then lack of staff education, patient education problem, then check system, the lack of quality control in the checking system, then physician's knowledge. Next slide. So how to minimize this prescription error? Whenever the drug history is to be taken, it has to be taken fully so that what type of drugs are being already taken and what type of drugs are given, right? So is there any contraindication? As we are telling, the salbutamol and atenolol should not be combined together. Next slide, please. So there are few, next slide, please. So dispensing errors, how to reduce the dispensing error? Only best method is go for e-prescriptions, that is computerized prescription order entry and the barcoding system. A lot of literature says that more than 80% of the dispensing errors are avoided when they go for barcoded system. Next, please. So give the medication to the computer before you give it to the patient. Next. So you have to check whenever you dispense, how much is dispensed, whether expiry date is there or not, label, then product. So check with the correct product whether it is given. All the 5 rights have to be checked. So whenever you dispense these combinations, you have to be very, very careful. For example, antibacterial, say levofloxacin is prescribed. So NSAIDs should never be combined with levofloxacin. The prescription may have this combination, but instruct the patient not to take it together at the same time. Spacing has to be given whenever it is. Because when the antibacterials and NSAIDs combination, there are a lot of reports that it can even lead to epilepsy, especially on levofloxacin. A lot of reports are there. Similarly, beta blockers and anti-asthmatics, anti-diabetics, and antipsychotics, it increases or it destabilizes the sugar control in the body. Then anti-gout drugs with AC inhibitors, the BP control is lost. Again, PPIs with anti-epileptic drugs and diuretics with ulcer healing drugs and anti-diabetics with corticosteroids. So these are the a lot of drug interactions are observed in these combinations, and whenever the prescription contains these combinations, it has to be taken care of properly by the pharmacist. Next slide, please. So how to minimize this administration error by the nurses? Check the patient identity, update the knowledge about medication, never guess about the medication. Any clarifications to be cleared before the administration of the medication, minimize the interruptions during the ward rounds, and ensure the medication is given at the correct time, and check for the correct dose calculations, and have the prescription drug and the patient in the same location for verification. Next slide, please. So confirm all the rights. As I said, there are 5 rights. Apart from that, the right of documentation, that has to be rightly documented also. Right patient, right drug, right dose, right dosage form, right route, right time, right education. Next slide, please. So most of the literatures, they say that the healthcare workers are getting fatigued whenever they are doing the work. So whenever they do the work for 8 hours, not only mentally, physically, also they're tired, and this fatigueness can lead to a lot of errors, especially the long working hours, shift work, the emotional stress for the nurses. And it was found that around more than 80% of the nurses are particularly affected with the fatigueness, and because of that, a lot of medication errors are observed. Next slide. So major root cause analysis have to be done to reduce the medication errors. What are the causative factors for the medication errors? And is there any sentinel events which can trigger the investigation and identify to improve the system and process, which can help to prevent the future errors? Next slide, please. So creating an effective reporting method. So I'll say here it's pre-intervention, intervention, and post-intervention phase. In the pre-intervention phase, you have to encourage the voluntary medication error reporting, and they have to monitor, all the reports have to be monitored on the daily basis, and see to it that there is a comprehensive monitoring of the medication handling stages, and review the records and find out the incidence and type of medication errors. And in the intervention phase, you have to conduct the quantitative and qualitative analysis of the collected reports and apply various analytical methods such as root cause analysis to identify what went wrong and where it went wrong, and develop the targeted training programs, especially the continuing education programs about the medication errors. And in the post-intervention phase, find out to what extent the adherence of the reporting protocol is done, and recollect the data and compare it with the pre-intervention data, and emphasize the national reporting of incidents through organization system or online electronic forms. Next slide, please. So here are the other possible measures to reduce the medication errors. Mapping the medication process, that is starting from the prescription till the patient receive the drug, mapping the medication process, and weekly error reporting and trend analysis, segregation of error types, and strengthening the auditing process, and implementation of the new intending module, separation of lookalike and sound-alike drugs with Tallman lettering, and light verification methodology for IV fluids, and pharmacist-led order rechecking process, disturbance-free intending, and staff reorientation and training programs, strengthening the medication reconciliation procedures, and providing a pocket-sized drug formulary for ready reference, online access to drug formulary and information software, and customize the drug chart, and staff engagement activities focusing on medication safety. Next, please. So here is one example. For example, in surgical ward, in one hospital, they wanted to implement this to reduce the methodology to reduce medication error, and they found it successful. That is PDSA cycle, that is plan, see, and act cycle. So what does this plan, do, and study and act cycle? They implement the barcode medication administration, they train the nurses, and develop the data collection process in the planning methodology. And they launch this in pilot scale in only selected units of the hospital for 4 weeks, and they monitor and adhere to the scanning by nurses. They collect the data on medication errors during this period, and they study this. They conduct interviews to understand whether the nurses are using this process properly or not. They analyze the data and identify the challenges. And based on these reports, they go for the future training for the nurses and strategies. Next slide.
Sorry to interrupt you, sir, but we are out of time and need to wrap this up.
Yes, madam. Another 3-4 slides. That's all. I'll finish it. Let me go to the next slide, please. Yeah, this reporting culture of medication error, there are 4 important things. One is the knowledge about the medication, the attitude towards the medication, the barriers, and the facilitators. So whenever the concept of medication error is explained properly, what is the importance of medication error, what is the reporting form, whether it is available, where it is available, how to report, all those things comes under the knowledge. And attitude, positive attitude and uncertain attitude. That means whether all the medication errors are to be submitted or report based on the severity or type of the error. The barriers include the lack of time, tiredness, fear of blaming, whether they may get any punishment, lack of confidentiality, right? Absence of an effective feedback, and the facilitators, that is removing the blaming culture, giving incentives for error reporting and ensure confidentiality. Next slide, please. So there are barriers in medication error prevention, mainly 4 barriers, that is lack of knowledge, skill, expertise, and confidence. Next, please. Next slide, please. So just a few points to recall here. Please keep clicking it. The first point, you have to be vigilant with the high-risk medications. Ensure the computerized prescription order entry, that is e-prescription barcoding system. See to it that all the rights of medication use are followed, and perform the root cause analysis and ensure that patient understands the drug and the disease well, and check for IV incompatibilities before administration. At the last but not the least, the continuing education program has to be, please click it. Continuing education program need to be done for the healthcare professionals. So it's a teamwork by all the healthcare professionals. Thank you very much for the opportunity.